We're meeting on the lands of the Wurundjeri people, and I'd like to pay my respects and warmly acknowledge that sovereignty has never been ceded, always was, always will be Aboriginal land. I hail from the country of the Dja Dja Wurrung, which has been protected and nurtured by the Djarra peoples, similarly to the Wurundjeri, for thousands and thousands of years. I'm so privileged to live in this extraordinary country because of the work that our First Nations peoples have put into ensuring that our land is nurtured and protected in the way that it is. I'd also like to acknowledge the lived and living experience in the room today. The topic that I'm speaking on, much like Bianca, is looking at the intersections of gendered violence and domestic, family and sexual violence. And so I'd also like to acknowledge the women and children that continue to lose their lives in the context of DFSV every day. And this is certainly a terrible year for our experience of DFSV. So possibly a good time for a policy change. So my name's Meg. That bio is a bit ridiculous. I'm sorry about that. I'm very fortunate to work at VAADA with the extraordinary VAADA staff here. That's why I got the gig. So if you've heard what I have to say before, feel free to hurry me up if you need to. This work was presented by me, but it's been co-written with my colleague, Associate Professor Daniel Tyson, recently Associate Professor. I'm still stuck on Doctor. I suppose a bit of an overview on why we need a gendered drug policy before we get right into it. Our current drug policies disproportionately affect women, gender diverse folk and young individuals in ways that are often overlooked. Women, especially mothers, face and experience significant stigma, and they're punished more severely than men, with their roles as caregivers weaponised against them. And we've heard that already today. Gender diverse folk encounter discrimination and violence when seeking support, both in healthcare and in legal settings. These disparities really highlight the inadequacy of a one-size-fits-all drug policy. Substance use is often a coping mechanism for trauma linked to DFSV, domestic, family and sexual violence. However, current drug policies criminalise these survival strategies instead of offering support, exacerbating harm. We need trauma-informed, violence-aware approaches that view substance use in the broader context of survival and not as a moral failing. Additionally, drug policies have been shaped by male-centric perspectives, ignoring the unique needs of women and gender diverse folk. Women face greater systemic discrimination than their male counterparts, with little regard for the added burdens they carry, such as mental health challenges, poverty and gender-based violence. A gender drug policy would address these realities, reducing stigma and providing tailored support, some of which we've thought about in our dreams from previous presenters. Children and young people also suffer when caregivers are punished for substance use. A gender drug policy would adopt a family-centred approach, focusing on keeping families together and providing supportive services to caregivers, ensuring children are supported while their parents are treated with care. In short, a gender drug policy is crucial to addressing the lived experiences of women, gender diverse folk and young individuals. It would move us to a more compassionate, trauma-informed and equitable system. We're going to cover the realities of substance use for women and gender diverse folk using this structure. We're going to focus on 4 key areas: the legislative landscape that currently exists, the realities of why women use substances, many of which you'll all already know, the impact of hyperincarceration and family policing on women, families and communities, and why all of these considerations lead us to explore the innovation presented by Portugal and beyond to consider a gendered drug policy. In Australia, we hold 2 contradictory approaches to drug policy. On one hand, we have a harm minimisation policy that locates substance use as a health need and seeks to reduce harm, but on the other hand, we maintain a punitive approach that views substance use as a moral failing, a behaviour that requires correction and punishment. These 2 policies are at war with each other. the state-sanctioned harm caused by criminalising substance use directly conflicts with harm min efforts. While one system perpetuates punishment, the other becomes ineffective in truly reducing harm, as criminalisation continues to undermine the health-focused approach, reducing the effectiveness of treatment and creating significant barriers to engagement. For example, while programs like NSPs have helped to reduce harm, women and gender diverse folk who use substances and face violence often report being treated with suspicion and judgment, limiting engagement. This reinforces the notion that their substance use is seen as a personal failing rather than the mechanism of survival or response to hardship, trauma, isolation, all experiences within the social determinants of health that exist as a health need. Australia's drug policies are also rooted in frameworks influenced by the US war on drugs, emphasising control and punishment over rehabilitation. This has created a disconnect between drugs, drug use and broader social issues such as DFSV that drive it. The result is a fragmented approach where drug use is criminalised and the harm minimisation framework can never be effective. In contrast, gendered violence policies like the National Plan to Eliminate Violence Against Women and Children and the MARAM framework in Victoria aim to address DFSV, but they often fail to fully account for the experiences of trauma and the unique challenges faced by women who use substances. There is no consideration within policy for how gender-based violence intersects with substance use, leaving many women and gender diverse folk without appropriate support. For instance, women who use substances to cope with trauma of DFSV often find themselves excluded from social services and support services, such as specialist family violence refuges, due to abstinence-based policies. This creates a really dangerous gap in our system, where those most at risk, most likely to be murdered as a result of DFSV, who may be using substances as a result of coercion or to survive trauma, are denied access to critical specialist support. Additionally, when women and gender diverse folks seek help from the police, they're more likely to face mandatory interventions if perceived as intoxicated, rather than seeing charges laid against their abuser. This bias underscores the stigma our national and state policies cause and empower, based on perceptions of substance use as an individual issue. This further vulnerabilises our community and also prevents them from receiving appropriate care. Our current approach reinforces both gender-based violence policy and drug policy, which spreads and empowers this harmful narrative that substance use is a moral failing, stigmatising women and gender diverse individuals who are disproportionately impacted by societal bias and settler colonial ideologies. By framing substance use through a moralistic lens, we ignore the structural and socioeconomic factors that drive people to use substances. Despite significant investments in law enforcement, substance use rates in Victoria remain stable, a pattern seen internationally in countries that criminalise substance use. Punitive approaches which focus on correcting behaviour and view substance as a moral shortcoming perpetuate stigma and bias, disproportionately affecting women and gender diverse folk. The criminalisation of substance use deepens this harm, amplifying systemic oppression. International examples such as Portugal show a different approach. There, substance use is treated as a health issue with a focus on harm reduction and support services within the policy environment that fully supports harm minimisation through the decriminalisation of substance use. What we've learned from this approach is that decriminalising drug use reduces the fear of criminalisation, which is critical for women and gender diverse folk who already face higher societal stigma. In partnership with Decrim, Portugal has reinvested in social supports including treatment, rehab and social services. What we've learned is that a health-first approach that links people to social support and treatment rather than penalising them greatly improves outcomes for women and gender diverse people who need trauma and violence-informed care. We know that women and gender diverse individuals are at high risk of using drugs in unsafe conditions, particularly if they're homeless, in abusive relationships or excluded from social services. Due to Portugal's dual approach to Decrim through harm reduction and an investment in social services, there's been a significant reduction in drug-related harm, including HIV and overdose deaths. However, despite this incredible success, there have been criticisms about the lack of gender-specific services that and support systems tailored to the unique needs of women and gender diverse folk. Gender-based violence, caregiving responsibilities and the social stigma associated with being a caregiver who uses substances remain unaddressed in Portugal's policy. Additionally, there's a need for more culturally sensitive and inclusive services for gender diverse folk. Even in progressive drug policies within progressive socialist countries, policy integration is challenging. While our current approach in Australia reinforces harmful narratives of substance use as a moral failing, we can continue to look to international alternatives. The World Health Organization recommends Portugal's decrim approach as leading evidence-informed policy. However, they've expanded their understanding as well. Who are considering recommend considering regulated safe supply, considering the risks associated with unregulated substances, and reinvesting in social supports. This aligns with their policy response to substance use within a health-based approach rather than a punitive one. Who have also advocated for the development of a gendered drug policy, something that very few countries have adopted. Such a policy would ensure that women and gender diverse folk are supported with compassionate, trauma, healing and violence-informed care, an approach that not only addresses substance use but also responds to the unique experiences and intersections of gender-based violence, trauma and systemic oppression. By aligning our response with health-focused models, we can break the cycle of harm perpetuated by criminalisation and create pathways for healing. Before we dive into the specific realities that women and gender diverse folk face and why WHO would recommend a gender drug policy, it's essential to understand the profound and compelling impacts of trauma. Trauma from experiences like domestic and family violence doesn't just affect someone emotionally, it fundamentally alters the brain's response to stress and can lead to long-term cognitive, emotional and physical health issues. Prolonged exposure to trauma is particularly damaging, compounding over time and making recovery much more complex. I'm sure we all know that. Structural barriers exacerbate these issues. Women and gender diverse folk often face significant challenges in accessing mental health care, including long delays, high costs, and limited availability of services. These barriers are compounded by the legacies of outdated psychological concepts such as hysteria, which pathologized women's responses to trauma and perpetuate stigma around mental health needs. In addition to mental health challenges, prolonged experiences of trauma can also lead to chronic physical health issues, as detailed in VAADA's Women in Pain submission. For many women and gender diverse folk, the physical pain from violence itself is compounded by the lack of access to comprehensive care that addresses both the physical and the mental health needs. In these cases, substance use may emerge as a coping mechanism to manage the emotional scars of trauma and the unrelenting physical pain they endure. Now let's begin our exploration of why women and gender diverse folk use substances. Substance use is not an isolated issue for women and gender diverse individuals. It is deeply tied to experiences of trauma, violence, poverty, marginalisation, and the pressures of rigid gender roles. Social and cultural expectations often demand that women conform to specific norms around behaviour, caregiving, and sexuality. Substance use is also influenced by the societal expectations around body image and appearance, influencing substance choices. Women are more likely to prefer substances that don't involve injection or that won't lead to specific weight gain, given the pressures to maintain certain physical appearance. For instance, some women avoid substances that they perceive as harmful to their body image, preferring to use stimulants which can suppress appetite or provide energy for caregiving roles, while others may choose drugs that can be taken in less visible ways, avoiding the stigma tied to injecting use. In some cases, substance use becomes a tool for conforming to these gendered expectations. For example, some women may use substances such as GHB and other drugs to keep up with the sexual drive of their partners, especially in response to expectations shaped by pornography and societal norms around sexual behaviour. Here, substance use becomes a way to meet the unspoken societal demand to keep him happy, while also managing caregiving responsibilities, as well as emotional labour within relationships. Beyond this, many survivors of violence use substances as a mechanism to cope. particularly when access to safe and supportive services is limited. Survivors of DFSV may use alcohol, methamphetamines or opioids to numb emotional pain or to manage the mental impacts of trauma or to manage the physical pain they've experienced. These substances may offer a temporary reprieve from the overwhelming burden of trauma, even though they exacerbate the systemic harms and stigmas already facing these communities. Women and gender diverse folk face complex and interwoven challenges, and their substance use is frequently a reflection of these broader issues, not merely a bad choice or a moral failing. It's critical that we understand these realities as we discuss how to shape policies and provide support that meets the distinct needs of women and gender diverse folk. Substances are often weaponised in the context of DFSV. I think we've already touched on this today, so I don't know if I need to go into it, but VAADA have created a tip sheet on how to identify some of the tactics and the ways in which substance use is exploited in the context of DFSV. There are a unique set of tactics available wherever there's a system that's going to be weaponised, and this is one such system. So I don't think I need to go into that with that room of experts. But if you have questions.
Is that going to
Yes, yep. So it's not on the website, but just reach out and we'll email it through. We also know that those who use substances face significant stigma and criminalisation, especially if they come from vulnerabilised communities. I'm sure that you all have many examples of community you've supported who've experienced ongoing systemic and social stigmatisation. This stigma pushes women and gender diverse folk into cycles of abuse and substance use, making it even harder for them to access the services they need. Criminalising substance use not only punishes those experiencing DFSV for their coping mechanisms, but it also exposes them to additional harm, often distancing them further from potential supports. We know that women and gender diverse folk experience greater harms associated with substance use, yet gender norms around traditional concepts of femininity create significant barriers to accessing support. What we put in our policies matters because it shapes how our community experience and receive support. In practice, we see inequitable case plans every day. For instance, mothers whose children are in care are often expected to remain completely abstinent from substance use, while fathers are only required not to be intoxicated during access. This double standard places an unfair burden on women, making it harder for them to comply with these expectations and regain custody. Substance use is often weaponised in ways that disproportionately impact women. We see women losing their jobs through image-based abuse, where their substance use is exposed in ways that men rarely experience. We also see women being misidentified, facing criminal charges or being convicted based on perceptions of intoxication when police arrive. The impact is even more severe for our First Nations women, who are dying at higher rates from overdose due to systemic failures to provide culturally safe, accessible care. Colonial legacies continue to harm our community as women face heightened risks of harm and death and are disproportionately criminalised for substance use. As we've explored why women and gender diverse folk use substances and the intersectional realities that they face, it's important to recognise that the stigma and criminalisation tied to substance use doesn't exist in isolation. These biases are deeply embedded in policy frameworks that perpetuate systemic oppression, especially within AOD treatment models. The AOD sector's treatment models have historically been developed with a focus on male experiences of substance use. This male-centric approach often overlooks the unique challenges and trauma and societal pressures around gender norms experienced by women and gender diverse folk, particularly those who are also survivors of gender-based violence. Male-centric care tends to emphasise strategies like confrontational inquiry, motivational interviewing, and abstinence-based models, which may not align with the needs of women and gender diverse individuals whose substance use is often rooted in misogyny, trauma, and survival. Women and gender diverse folk, for instance, may use substances as a response to abuse where trauma and safety concerns are paramount. However, male-centric models often don't account for these underlying drivers, instead focusing narrowly on reducing substance use as a primary goal. This approach can be re-traumatising especially when treatment is offered in mixed gendered environments where women and gender diverse individuals might feel unsafe or where their trauma is overlooked. In these settings, the complexities of their lived experience, such as caregiving responsibilities or surviving violence, are deprioritised, and they're pressured to conform with a model that was not designed with their needs in mind. Additionally, abstinence-based programs that expect immediate and total cessation of substance use can be particularly harmful for women and gender diverse folk. For many, substance use is not merely a choice but a means of survival, especially in abusive relationships. In these contexts, substances may also serve as currency. They can be used as a way to negotiate safety or to mitigate further harm in coercive situations. The expectation to quickly achieve abstinence without understanding these dynamics can remove this currency, leaving women and gender diverse folk even more vulnerable and at high risk. Such rigid timelines, often prioritised in male-centric care within our AOD treatment settings, fail to account for the ongoing need of safety and stability. These programs don't provide the time and support needed to process trauma, to heal and to build secure environments. And we heard the benefit of Shark's supported residence and THM model from our experts on the stage. For mothers, these models present even more challenges. Male-centric approaches rarely account for the burden of caregiving or the fear of losing custody of children, which disproportionately impacts women. The expectation to engage in treatment while managing the complexities of parenting and surviving violence places women in an untenable situation. For example, they may be expected to attend regular treatment sessions or call-ins, but the rigid nature of these programs makes it difficult to abide based on living conditions and the limited resources they have available to them. This selective systemic oppression is not just isolated to treatment settings, it extends to legal responses as well. Hyper-incarceration is a prime example of how our policies disproportionately target specific communities, particularly First Nations women and gender diverse folk. I'm just going to skip the next slide because I'm taking a bit long. The rising rates of incarceration, particularly among First Nations women, are not simply about substance use or crime. They're deeply tied to systemic poverty, gender-based violence and survival crimes like theft, offences often committed out of necessity rather than criminal intent. In Victoria, for instance, 40% of incarcerated women face charges for drug possession, while the majority are charged with theft. These charges often reflect a socioeconomic precarity women face, not deliberate criminal behaviour. Many report that their offences, such as theft or drug possession, were driven by poverty, abuse or addiction. Around 75% of those in the research had used substances in the year prior to their arrest, underscoring the deep connection between DFSV, trauma and substance use. This surge in incarceration is a consequence of policies that disproportionately target and criminalise specific groups. Incarceration of women is the highest growing cohort and has risen by 700% in the last 30 years. 30% of our female prison population are First Nations women. So this surge in incarceration is a consequence of policies that disproportionately target and criminalise specific groups. These policies lead to the hyper-incarceration for survival-related offences, perpetuating colonial systems of control and punishment. One of the most devastating consequences of punitive drug policies is the surveillance and policing of families, particularly mothers and caregivers who use substances. First Nations women and gender diverse folk are disproportionately targeted by child protection systems facing the removal of their children. Child removal becomes a weaponised tool of control, echoing colonial practices of forced assimilation and cultural genocide. And I'm sure that we've all supported First Nations women who are terrified of having their children removed, and probably we've supported women who have had their children removed. The cycle of criminalisation is deeply rooted in colonial structures designed to regulate and punish. Hyper-incarceration and family policing work hand in hand to trap individuals in a continuous loop of criminalisation, surveillance and trauma. Systems like the judicial and child protection systems are structured to manage populations deemed deviant by the state rather than offering pathways to healing and recovery because of our current policies. Women and gender diverse folk are subject to intrusive assessments such as supervised urine drug screens and compliance checks that focus on substance use while ignoring the underlying causes. These assessments are taken with someone standing over you, and for those who've experienced sexual violence, these approaches can be especially harmful, triggering further trauma that directly leads to your use of substances. The threat of family separation, combined with punitive legal consequences, often deters women and gender diverse folk from seeking help. I'm just going to skip ahead. Okay. Australia's drug policies reinforce patriarchal structures that disproportionately impact women and gender diverse people. These policies criminalise substance use without addressing the gender drivers such as DFSV, economic coercion and socio-economic vulnerabilisation. As a result, women and gender diverse individuals using substances to cope with trauma are forced to align to rigid social expectations and to manage experiences of poverty and depression, and then they're punished. Portugal's approach decriminalises drug use and treats it as a public health issue, focusing on rehabilitation and harm reduction rather than punishment. This model provides trauma-informed care that addresses the root causes of substance use, reducing stigma and supporting social reintegration. Australia can learn a lot from this shift by shifting from a punitive model to one that acknowledges substance use as a health issue, especially for women and gender diverse people. However, in order to address these disparities in substance use by gender, we need to go further. We need to regulate safe supply of substances and invest in models of care that address the social determinants of health and underlying significant factors that cause substance use. Australia has a critical opportunity to reform its drug policy and shift toward approaches that better align with the lived realities of women's substance use. A gender-responsive drug policy would not only address the gaps in treatment, but also create safer, more inclusive spaces for women to access trauma, healing and violence-informed care. By integrating mental health support, legal services, housing assistance, the needs that are identified by women into treatment outcomes will improve. Fundamentally, we need a gendered drug policy that acknowledges the settler colonial ideology causes and amplifies harm and a policy that actively works to address this harm through integrated policy that considers the spectrum of human experience rather than functioning by identity and in silos. Because we deserve policy that considers and celebrates our humanness and treats us with compassion, not harm. Thanks.